Hello, everyone. Welcome to today's webinar. Our topic today is how to improve poor data quality across the healthcare ecosystem and make workflows manageable, hosted here by MedCity and sponsored by IMO Health. Today, we have a fantastic panel of speakers who sort of represent groups across the healthcare ecosystem with a lot of really interesting insights into how data and workforce intersect. And I'm really excited to hear from especially some of their insights into what the future of data and workforce issues will look like when we think about new technologies like artificial intelligence, ChatGPT, machine learning, and natural language processing. So to kick it off, I'm going to go around to our panel speakers and have them introduce themselves briefly so you get a sense of who they are and what their background is and what views they bring to this. And then we'll kick right off into a hopefully rousing debate and discussion of these issues. And as always, love to have audience questions, comments, and thoughts into the chat in the Q&A section, and we'll hopefully get to them near the end of this discussion. So I'm just going to go around and have Amal start off. Amal, go ahead and introduce yourself.
Thanks, AJ. Hi, everyone. So Dr. Amal Balla, I just go by Amal. I'm based out of here in Phoenix, Arizona. So we basically observe two types of weather patterns here. Been out here since 1985. My background is basically working really heavily in the secondary use of clinical data. So I'm the former director of clinical informatics and data science at a real-world evidence, real-world data organization. I am the senior director of clinical informatics here at IMO. Really been working hands-on with the data and trying to make it as usable as possible for a lot of fun use cases. So I will go ahead and pass the baton back to you, AJ.
Thank you. And Julia, do you want to go next?
Sure. Hi, Julia Skapik. I'm an internist and board-certified clinical informaticist. As you can see, I'm in my federally qualified health center clinic that I work at a couple days a week right now. But my full-time job is as the CMIO of the National Association of Community Health Centers. In my previous life, I worked for the Office of the National Coordinator for Health IT during the Meaningful Use and 2015 edition stages. And I also serve as the board chair-elect of HL7 International, which is a health IT standards development organization.
Thank you. Next.
AJ,
do you want to introduce yourself?
Okay. Hello, everyone. My name is Jingqi Wang. You can call me JQ. I'm the CTO at the Melex Tech, now part of IMO. I assume I'll have an IMO title really soon. So my background is computer science, biomedical informatics. I've been working in clinical lateral lung processing, software application development, and then work with team and also customers, including health IT company and also hospitals develop the information extraction system using the NLP technology and then build downstream applications on top of the NLP output.
Fantastic. And Nate.
Hey everyone, thanks for having me. I'm Nate Favini. I'm a practicing general internist and also a clinical informaticist. Like Julia, my background is also in the federally qualified health center world. That's awesome to hear. And I've worked in FQHCs and Medicare Advantage, and I'm now the chief medical officer at a company called Forward, which is a primary care startup based out in San Francisco, where we're really trying to rebuild the healthcare system with technology at its core, starting with primary care.
Fantastic. And I'm realizing I didn't introduce myself at the top of this. So hello, everyone. I'm AJ Holmgren. I'm an assistant professor of medicine here at UC San Francisco, and also a researcher who studies health policy, informatics, and digital health. And so I want to just dive right in today and talk a little bit about sort of the topic of challenges with poor data quality. So I think everyone who has worked in healthcare at some point has run into data issues and data quality issues. And I think a lot of people really don't even have any idea of how widespread these issues are and how they touch every different aspect of healthcare delivery, payment, and policy. So thinking about how you've explored the challenges you faced in your role due to poor data quality and how that's impacted your work, I'd love to learn a little bit more about sort of what are the challenges that you're facing and where is this failing providers and patients? I'm just going to call on people at random to start. So I'm going to start with Julia.
Yeah. So, because I work with individual community health centers, over 1,400 such organizations in the country, I can say that all of them know of this problem of data quality. One of the things, though, that many people don't do is actively do quality improvement on their data quality itself, right? I think many folks say, our quality measure scores are not that great. But if you actually do an analysis of the quality measure score, it's only as good as the data that supports it. So a good example that I like to use is breast cancer screening. So because mammograms happen in imaging centers, it's usually not within the scope of the electronic data transmission of a health center. So there are a bunch of different ways that we could go about getting that information, but many organizations actually sort of rely on that information to be sent back. Oftentimes it can be in some sort of electronic PDF. Some places even will get the patient to sort of report that they've done it. Some systems can say, yes, it was done, but may or may not show the result in any kind of structured way. So if our goal is to really, note if that score of 30% is accurate, we need to do chart reviews. It's sort of an intensive activity. But what we find as we do those reviews is there are a lot of opportunities to get that score to be accurate. And the example that I also use is COVID, right? So our health center at the beginning of COVID did not have access to immunization data. So we were calling all of these patients who went to a mass immunization site or went to a drugstore and got a vaccine, but we didn't know that. So we were wasting all this energy going after people who didn't have a care gap when we wanted to be focused on finding those people who did. So the more that we look at the data and improve the data quality, the more we actually save time and energy in focusing on the care gaps that are real and helping those patients who are missing that care.
I love that. Such a great concrete example, both in terms of, everyday practice as well as what happens in a crisis event like the COVID pandemic. Does anyone else want to sort of pick up on that thread and talk a little bit about, data quality issues and how that's challenged your work?
So I could jump in a little bit into that, AJ. So as I did my introduction, my background is a lot in the secondary use of EHR data and really working in data strategies from single sources to multi-sources. When I say multi-sources, that's like not only within a health organization, different type of sources, we're saying even multiple health systems providing data. When you look at that data at scale, you kind of do a head tilt because and kind of reflect on how data is aggregated from the start and the get-go. If you look at the inputs into the entire ecosystem, taking a step back, I always chuckle is that the ball starts rolling when a provider says, in my opinion, you're exhibiting this, or you have the features that describe this pathological outcome. And that type of opinionation is really propagated through every single aspect of the EHR, and then also goes down into the secondary usage of that data too. And so from that lens, I see a lot of ways that where technology and our approaches really help kind of, I like to say, harmonize the data to make it at least some type of semblance of utilization. And it's such a unique healthcare, unlike any other industry, is very unique in that aspect because a lot of the data originates from that statement, in my opinion. So I'll pause there.
No, I think that's a really important point, and it sort of illustrates the challenges when people who are not informaticians ask me, well, why couldn't we do sort of the big studies cross-institutionally that came out of the NHS during COVID, for example? And here, we find that there are a lot of challenges harmonizing data across multiple sites, or even within the same site, across even just different clinics or different physicians. What's kept on the problem list and what's in a structured field versus what's in a clinical note in an unstructured field is really challenging and can vary really wildly, between sites, but also within sites. And as researchers, it's a serious challenge, and it really inhibits our ability to quickly scale up our research infrastructure in these moments of crisis. And I think that really held back a lot of really important research during COVID, and it continues to hold back researchers now. JQ and Nate, do you want to talk a little bit about some of your thoughts on this?
Thanks, AJ. Can I jump in on the unstructured text part? So overall in the healthcare system, generally 20% data available in the structured field, and 80% of the information actually available in the clinical notes. The natural language processing need to extract information from the unstructured notes and then convert that into structured format, facilitate the downstream applications. During the NLP implementation, we do see a lot of quality issue of the clinical notes from both the formatting perspective and then content perspective. For formatting, we see usually what happens when the nodes transfer across system boundaries, for example, from EHR to a outside clinical data warehouse, I see lots of those formatting information actually lost. There's no line break at all, no sections. Sometimes there even no space between the words. This is not even, we're not talking about build a fancy NLP model on that. So before those NLP model, we need to address those formatting and also those kind of pre-processing. So this kind of will result in a longer NLP project implementation, extra step on the data cleanings. And another challenge we are facing right now is lots of the patient data actually it's in the scanned PDF format. It's image there. So you have to run OCR, right? Convert that into text and then apply NLP. And then OCR itself is not 100% accurate. It has errors there. So all these errors actually will result in either miss the information from the NLP output, or it will have false information from the NLP output. And then another point from the content perspective, I also see, the expectation of NLP tracking information from notes. Majority of the case, we are extracting the patient-specific information. But in the clinical notes, we see sometimes the notes have those educational material, information material, something like a sentence, lung cancer claims more lives in US compared to breast cancer and liver cancer. NLP can easily extract breast cancer, liver cancer, but that doesn't belong to the patient. So those kind of we should say, maybe we should not say that's noise, but a general information, educational material also bring a challenge to the NLP information extraction, and then a challenge to downstream applications.
I really love this answer because it touches on so many different aspects of the challenges of using EHR data, and that, data is not created equal. And some of this is blurry PDFs and things are sort of all over these unstructured fields. But it also touches on this really important point of, EHR data serves so many masters. So when you talk about the educational information in a note, that's because not only is that note for the provider who is doing the documentation and for the provider who will see that patient next, it's for the patient as they have access to clinical notes, and it's for researchers, and it drives billing and quality measurement and other administrative tasks. And I think that's one of those core issues of how we work with EHR data, is that these don't serve one purpose. There are so many sort of endpoints for where this data goes and what it informs, that, sort of navigating this through IT governance and through technology and through people is such a tricky web. And so that's why I'm really excited to be having this webinar. Nate, I'm going to give you the sort of last word to talk about some of the challenges of data quality that you've sort of experienced in your role.
Yeah, all of this really resonates, and it's almost like I can think about all the different roles that I've had in the healthcare system and identify the challenges by that role. As a practicing primary care doc, I can't even count the number of times where I'm in a chart and I'm like, I can't figure out what's going on, because of the way the information is organized or because the information is incomplete. Then as someone who's trying to run a healthcare system, this was sort of the thing Julia was alluding to, is you're trying to figure out, is my health system doing a good job? And you often don't have the data to know, are you doing a good job or not? Third, as a health services researcher, you're trying to understand how the system as a whole works and put those pieces together. And you often don't know if you can rely on the data that you're using to make those inferences. And then fourth and last, in my current role, a lot of what I'm doing today is we're trying to build tools that can actually do the things that clinicians do, right? Like we want to build tools that can manage your software, that can manage your diabetes, software that can manage your hypertension, that can tell you when you're due for your mammogram without necessarily having to have a clinician in the loop, because we know we have a massive shortage of primary care clinicians in the country. And so we have to build tools that support our clinician workforce in getting these things done. And to do that well, you have to have this data in a structured form, because the tool can't action off of unstructured data. It needs to, and you have to be really confident in the data that you're using when you're going to take a clinical action on a human being off of that data. And so getting to the place where that data is structured and you have a very high confidence in it being correct is actually critical, I think, for the future of the types of tools that we need to build to really solve these challenges in healthcare.
Absolutely. I think that's a really fantastic sort of wrap up of some of these, issues in the way that poor data quality impacts our care delivery, and that, we're really held back by how much we can innovate with these fantastic new technologies by, all of this data being in sort of a messy, unstructured world. And that, building on that, I think the next topic that we wanted to really hit on was, what are some of the most major and salient barriers to getting from where we are now to a healthcare ecosystem that is full of clean, structured data that, someone can walk into a place like Forward Health or an FQHC or an academic center like UCSF Health and say, oh, I want to know all of your patients that have these conditions and, what medications they're on. And it's a simple 2-line query. What are some of those barriers, whether that's budget or payment or people or processes? I'd love to hear from really anybody on the panel who wants to pick that up first and lead us off, because I think that's really identifying where those barriers are is the first step.
Sure, I can take a first stab at that one. So I was just thinking, there were 0 minutes of training in my entirety of medical school about terminologies, computer systems, usability, human-centered design. I learned about all of those things later, and it really makes a lot of sense why we're not very good at being data entry clerks as clinicians, because, no one was teaching us that. I think one thing that we really need to do way, way, way more of is decision support on the data, right? How can I trust a piece of data? There's no information about the provenance of it. Why doesn't the computer validate whether or not a piece of information is accurate or current? Why doesn't the system organize information sort of in groups of related things so I can sort of look at and evaluate? In the outpatient setting, I think it's also made harder because there's not a requirement or a typical activity in every outpatient encounter to do a real reconciliation of all of the items in the record, right? And that's really just based on the fact that if you have 15 minutes, someone's there to talk to you about something, where are you going to get the minutes to go through a list of 11 medications, to go through a list of maybe even 19 problems? Because some of those things just sort of live in perpetuity as sort of this, weighing down the record. And what the system needs to do a lot more of is supporting me and being able to quickly say, yes, no, and, oh, I'm concerned about the patient's diabetes. Let me go to diabetes and see all of the information that's available there. I've spent countless numbers of hours having the patient say, I want this cream. Somebody gave it to me like a while ago, and I'm trying to figure out what was the date of that thing happening so that I myself can extract that unstructured data, or even structured data, but it's hidden in a view that I have to know what day it was to find it from the record so that I can take action today. We can do so much better than that using technology, but for some reason, we're not applying that in the way that it makes the most sense to me.
Yeah, I totally agree with all of that. And AJ, you asked a little bit about barriers, and the biggest barrier I feel like I've seen in my career is the incentives in our healthcare system. I'm sure all of you have seen that too. But in a fee for service system, it's just so hard to marshal the resources for these types of projects and builds that you need to do, because really the incentives don't support investing in any of this at all. The value-based care is probably better. We have at Forward, we have a subscription-based model. Our members are paying us directly, and we tend to think that gives us a really good set of incentives to go and massively improve our unit economics on the back end, because it's what will allow us to lower our price and serve more people. And so that gives us the right incentives to go and try to build these tools that will replace the things that our clinicians do. And that forces you to get all of these other things into place, right? Like it's the thing that is driving us to we built our entire EMR around structured data, and we built all of our workflows around anticipating that we were going to try to have software do things that clinicians do today. You can't do that in the fee-for-service system, because as soon as you take the clinician out of the loop, it's no longer a billable event, right? And so you can't make money at all. And so I think we have to move towards payment models that support this, to really go in the direction that I think all of us want to go in.
I love both of these answers because they really highlight how, while I think a lot of the times we think about data cleanliness as a technology problem, what it really is a workflows problem. And that workflow problem is driven by a payment problem, which is to say, we have this great opportunity to totally transform how care is delivered in the United States, and sort of integrate these sort of technologies, like things like remote patient monitoring or sort of continuous asynchronous care delivery. And yet sort of this fee for service structure has really constrained our ability to do that. And instead, what we've done is sort of digitize a paper-based world into a computer. And so I think, JQ has some interesting insights on this. I think, a lot of your work with the natural language processing is trying to make sense of this sort of fractured world using cutting edge technology. And so I'd love to sort of hear a little bit more about, some of the barriers that you've seen trying to take all this messy unstructured data that's getting input and turn it into sort of usable structured work.
Yeah, thanks, AJ. And I do like Julia and the net point about using the information extraction from the unstructured text support workflow, support clinical decision. So from what I can see from clinical notes, it's so flexible. I don't think there are any like a standard template. And I see, notes from hospital to hospital, it's different. From one specialty to another specialty, there's a different. I think this is like of standards on the documentation, clinical documentations. If it can have some like a standard like that, probably the input data quality for NLP will be greatly improved. But on the other hand, I also read the report say like 35% of the physician time is not working.
Did we lose JQ?
Oh, he might have frozen there for a second.
Create the high quality documentation.
JQ, you froze for a second.
I'm still active now.
Yes, we lost you for a second, but you're back now. If you just want to repeat what you last said.
Yeah, I always have the question, from NLP perspective, we love the clinical document to be as standardized as possible. But on the other hand, it will consume more documentation time from physician and from nurse there, right? So kind of we have to find a balance, how to define the documentation standards and without taking too much of the physician's time on documentation or on patient.
Sorry, I'm jumping in, but I think this is a place where I think generative AI has a huge potential to help us, where if we can that's the core tension, but generative AI has the potential to just break that. And if we could use that tool to dramatically reduce the burden on clinicians, because you can't ask doctors, especially like think of an environment like Julia's, like an FQHC, like ask doctors to spend additional time structuring data. They don't have that time. But if we can use these tools to structure the data for us, and maybe the clinician just has to review it after to make sure everything's right, that puts us in a much better situation.
Yeah, I can say that one of my least favorite activities is trying to find in a list of 100,000 options the right ICD-10 code. And I have already input so much information into the record. I don't understand why it's not helping me to suggest the code. And I just say, yes, it's that one. Or, oh, no, I didn't say left or right, or you didn't pick up left or right, so it's this one. Instead, I'm putting in things into a search bar, and the first 100 hypertension options that come up are pregnancy related, but I don't see pregnant patients. So every time I'm playing that game, and it's frustrating, but it also affects the data quality really significantly, because there's only a certain number of seconds or minutes I'm going to look, and then I'm going to pick a close enough answer and go on. So we could have much better input even from me if I had better support in figuring out how to find that answer.
Yeah, I agree. I think the expectation for NLP or generative AI technology basically is try to save the physician time by suggesting something. So physicians just say yes or no there. And the more accurate the recommendation from those models, I think the more efficient for physician to select from. That's probably the goal of the current NLP and AI technology is developing tool. We do see a potential. I think we have a topic about like a technology to solve some data quality. We can talk more there.
I like to come from a different perspective of generative AI. I do see the value of it, but I do see some interesting, I guess, barriers to entry in this. Generative AI, how do you train that model? First of all, what are the inputs that go into that model? If you take something off the shelf, JQ, you probably could jump into this even in a deep conversation. But if you take something off the shelf, it's not going to be very tangible or very relevant to our domain. That's an issue that you run with these large language models in general. The other aspect around generative AI is I find it very interesting seeing the variability of the opinion that the physician puts into their SOAP notes. I find that very interesting. You'll find a lot of anecdotal information in there, which is normally not encapsulated if something is generated. So I personally find when doing analysis on corpuses of text, looking at clinical narratives, seeing that variability, seeing that the physician actually spent the time to document something which they could not document through the structured mechanisms, to be quite interesting. So.
Yeah, definitely. I think this is a really interesting sort of segue into one of these other questions that we have, which is thinking about recent technology can improve sort of this clinical data management and ease workflows. And so, we've started talking about it a little bit, but I'd love to hear, especially from our practicing physician crowd, like where would the generative AI be the most impactful for you? What are your pain points when you're seeing patients that you wish you could have something sort of generate from magic, if you could, which is sort of close to how large language models work, for those of us who are not pure computer scientists?
Well, I can say that right now I use ChatGPT to write all my disability letters and work excuses. That is a very useful space to use it in. I find that our EHR templates are hard to work with, and I still, I get a better result from ChatGPT. I think the thing I would most want help on is sort of closing those loops and saying, hey, this person had hepatitis C antibody, but I don't see a viral load. That's the next step in this chain. Why don't we talk to the patient and find out, is there missing information in the record, or is this person potentially able to be cured of Hep C? And no one has found that thread sort of dangling somewhere in the petabytes of data out in the world. So I think that would be one of the opportunities that would get really exciting, sort of say, I'm expecting this. Where is it? Why don't I see it? And that also helps us to close those data gaps, right? Because, if the data is in fact missing, but it could be brought in, then we can close that loop and move on to the next patient who really needs treatment.
Those are cool. Those are cool use cases. A couple other ones that come to my mind are visit scribing. I think there are a bunch of companies working on essentially like you mic the doctor, you listen to the conversation during the visit, and then writing the SOAP note based on the conversation that has happened. And the stuff that I've seen looks pretty good. The real interesting thing is, can you get that not just to write or like replicate what the physician would have written, but actually output the structured data that you then need for subsequent decision making. And then I think of things like, clinician inbox management, where you're responding to emails or chat messages from patients, and there's a huge potential to save time there using LLMs. They're still limited in a lot of ways, but a lot of people talk about the hallucinations that the LLMs do. I like to call them confabulations, because the doctors will appreciate that, because that's what they seem like to me. Like, it acts like it totally knows what it's talking about, but it's completely making up information. And so it's hard to you can't let the LLM actually provide medical advice to patients, because it will be wrong 5% of the time. But you could easily generate what the LLM thinks the physician or the clinician should say, and have them overread it before they send it, and save a ton of time in that regard.
Yeah, and I'll say, I think that one of the main limitations on using AI in this context is, what they teach you in medical school is 90% of every diagnosis is just the history, right? But you learn over years and thousands of patients how to draw out the information that's relevant or not to evaluating something. And the problem is, if I throw a bunch of spotty information that's incomplete at AI, it's not going to have enough information to go to the correct differential reasoning pathway. But if you use sort of an educated person to gather that information, and as Nate says, sort of up and down vote potential pathways and options, then I think it could be very powerful.
Yeah, I think this really hits on an important. Go ahead, Nate.
Oh, I'm sorry. So I'm yes-anding Julia, which is something we're working on in regards to that. Is can we have an LLM help us define what our care pathways ought to be, right? Like, feed it a bunch of scientific literature about a condition, prompt it, tell it to pretend it's a doctor writing a protocol for how to treat that condition. And then it'll come up with a pretty good version of what the care pathways there ought to look like. You can't have it actually be the one managing those care pathways for all the reasons Julia just mentioned. But it can help our clinicians define what those pathways might be, and then we can work on building those into our system.
Yeah, from tech perspective, I do see the large language model, generative AI, they have a lot of potential there. Technically speaking, the large language model, they have a foundation model trained from a general knowledge across different domains, and also those codes, including the human logic in it. Then another aspect will be we put the medical domain knowledge on top of the large language model, make sure it understands the medical there. Next step will be we'll put the patient-specific information, make sure large language model understands this specific patient before it throw any a medical decision there. I can see both challenge from the tech perspective, how to organize the medical knowledge and put that to large language model, or how to organize patient information input there. And also from a collaboration workflow perspective, those data, especially the PHI data, fine-tune that with language model, I think is still quite challenging now.
Destination format, and it should format it better.
Definitely. I think these are really great, because I think, a lot of us who are familiar with informatics probably think a lot about, the law of informatics, that the idea is to make it so that a physician or a human plus a computer and plus the technology is greater than either the human alone or the physician alone. And I think, when I've seen a lot of these big, hype studies coming out of the literature, like, oh, ChatGPT can pass the USMLE exams, ChatGPT gets this diagnostic right, ChatGPT creates notes that are as good as a medical resident. I think, well, this is almost asking the wrong question. Shouldn't our question be, how is a physician who is sort of augmented by ChatGPT, who is using it as an extension of their reasoning to either reduce their administrative burden or make themselves more efficient, how does that compare to ChatGPT alone, or how does that compare to the physician alone? So I'm excited to hear all of these, LLMs and AI as physician extension tools and ways to supplement us rather than replacing physicians entirely. So I think, this was a really great discussion. I think getting back to that idea about people, one of the themes of this topic and of this webinar is data quality and workforce issues. And I think, all of us in our various roles have experienced those in some way, in that, especially in this post-COVID world, we're really at, and Nate mentioned this, a truly crisis moment in a lot of areas where the supply of the clinical workforce is just absolutely far, far below where we'd like it to be. And if you go look at HRSA, the federal government's projections of what trend that's going to take, especially in primary care, there are going to be areas of this country that don't have a third of the amount of primary care physicians that they'll need in order to sort of meet that demand. And so, I'd really like to hear, from all of you about thinking about how data quality impacts this, both on sort of the data input side and the burdens of EHR documentation, and sort of on the ability to, as leaders in these organizations, to retain your employees and to prevent burnout.
Man, that's a real one. It's, I grew up in a primary care shortage area in rural Pennsylvania, and my dad is an emergency physician, and so I grew up every day on these stories of people he was taking care of in the emergency department who just shouldn't have been there, right? Because they didn't have good primary care, they didn't have good preventive care. Social determinants of health were driving them into the emergency department. And it's one of the reasons I wanted to become a primary care doctor. And I'm going on a long personal digression, but then I went after college. I was a Peace Corps volunteer in Mozambique. And Mozambique has one doctor for every 800,000 people. One doctor for every 800,000 people. So what I grew up in, and what I thought of as a physician shortage area, is nothing compared to Mozambique. And I really think our goal, and I think we have the potential to do this with the technology that is coming. I really think our goal should be, how do we get incredible primary care to every person on the planet, not just every person in this country. And so I'm really excited about the potential of these things. It's really clear that we can't rely on the workforces alone to get there, because we never will. There aren't enough of us. There won't be enough of us. And so we have to build tools that dramatically amplify the impact of every clinician that we have today. It can't be like, it's to set a goal of like every clinician will have 150% of the impact that they have today isn't adequate for reaching the needs of the world. It has to be like every clinician can have 1,000x the impact that they have today for it to really make an impact on the trajectory of human health, I think. And so that's the kind of stuff that I'm really interested in working on. And I think that would make the job of doing this work feel really different, right? If instead of sitting in a clinic, having 7 to 10 minutes with each person that you're with and feeling like you don't actually have the time or the resources to make a real impact on their health, if you felt like you were building tools that allowed you to impact hundreds of thousands of people, and you were seeing the most complex cases that the technology couldn't handle without your input, I think being a primary care clinician would just feel like a really different job than it feels like today. So that's sort of the world I imagine, or I hope for.
Yeah, and I think there are a couple obvious things to me. I alluded to human-centered design recently, but no one comes to me and asks, how do I make your experience better? What things are you wasting your time on? And if you think about how much the a tiny amount of waste is magnified by hundreds of thousands of people doing it over and over again all day, every day. I'm shocked that we aren't marshaling sort of all of this effort to both protect the well-being of our care teams and workforce, but also to stop wasting that time and money. Because we probably could work with far less staff than we had if we weren't doing a lot of these low-value activities. And there are some things which I think, I'll tell my medical assistant, I have a relatively recent one, but you don't have to ask me. If the patient wants a pregnancy test, do the pregnancy test. And, for preventive care, I don't know why I'm ever involved in ordering a mammogram. The person should be able to say, this is my history and risk, give me the mammogram. Like, there's all of these activities in which there's not a lot of clinical nuance, and where the patient should be empowered to take that on whenever and wherever without the assistance of a person sitting in an office or even at a computer. So I think looking for all of this low-hanging fruit would allow us to really sit down and work with people who are having a mental health crisis. I actually had a patient who came in last week, and she talked to me, she mentioned, oh, I have lupus. I'm like, oh my God, I think you have lupus pericarditis, right? Just sort of wandering into the clinic. Those are the people who, they need the help of someone to direct them to the right resources in the right time. A person, though, who sprained their ankle doesn't need me to tell them about rice in the office. They should rest. They should ice. They should compress. They should elevate. If they can't bear weight, they should go get it looked at right now and not wait all week, right? Some of these things are pretty straightforward. And so starting, as Nate was saying, to sort of tease out these care pathways and think about what's the right time and need for a person with a different level of clinical knowledge to intervene is really important for us to slough off some of these tasks that frankly are even better done by someone else. Like the diabetic nurse educator may be able to connect with some of my patients more than I do when they come in every 3 months and I tell them your A1C is way too high. Why aren't we taking our insulin? Someone could be calling them every week and working with them, right? So, those new models of care they will have an impact on thinking about, where is the value and how do we give the patient the power to do things that, frankly, I don't see I have any role in being involved in.
It almost sounds like leveraging. I love how, Nate, you put it in perspective, is giving us a little bit more of a force factor, and then leveraging our skill sets. Not maybe, I almost look at it as like a triaging. Is like the more not so complex cases we can triage a lot more effectively with technology, and then start leveraging technology to more complex cases like SLE-induced pericarditis. So I find that really interesting. So that's just me interjecting. Sorry.
No, that's great. And I think, one of the things that's really hit on is that healthcare is a team sport. And we talk a lot about team-based care all throughout the care continuum and the performance of teams, whether that's primary care, surgical teams, or ICU teams. But I think there's very little focus on team-based EHR work. And I think right now, we keep the physician or the treating clinician in the loop a lot more than is probably strictly necessary. And I think this once again gets back to some of Nate's points about how this is determined by payment models. And one of the reasons that MAs aren't able to take more command is, partially because it's hard to bill for things when there's not a physician sign off on many different procedures. And the other part is that, it's very challenging to retain workforce in clinical offices like that. I think there's a lot of stress that comes with working in primary care, especially, but across the healthcare ecosystem. And so these sort of workforce retention issues matter a lot because, when I've talked to practices that have, say, an MA team that has been working there for 5 years, and they've built these sort of relationships between the physician and the nurse and the MA, and they're really a high-performing team, they take on so many responsibilities and take a huge load off of the physician. And so when we talk about, how these things are interrelated, how is documentation burden and data quality related to workforce retention and burnout, it turns out that those things all feed into each other, where if you've got a high-performing team, you can take a lot of the administrative load off the physician. But if you don't, then it's much more difficult to do so. And so I think a bunch of these were really fantastic notes on thinking about how this works. I think, one thing that I would really love to hear a little bit more about is, what is something from your experience that has overcome a data quality challenge, which is to say, where did you find sort of a concrete issue? And was it technology or people or governance or management that helped sort of overcome that problem? Because I think people are really interested in sort of thinking about, where do we tailor these challenges? How do we identify what the right solution is and implement it? So I'm happy to toss this out to anyone, because all of you, I'm sure, have a lot of experience in this domain.
I can share some of my experience. So the unstructured text quality issue I mentioned before, majority of them is actually solved or partially solved from the technical perspective. So it's just like if lost format, then build the AI models to recover the format. If the spell misses spelling, then build the AI models just to correct the spelling there. Because the NLP is more on extracting information and then unlock the possibility of downstream applications. It has like a little control from the source upstream part. And another point that I do see recently with the large language model, even if we are not talking about the generate a lot of patient information on the data cleaning or improve quality itself, I see large language model is very promising. We mentioned the OCR errors. Actually, the large language model, like a GPT-4, it can fix the majority of the errors there. And also formatting issues, some of the general mention issues. Before large language model, we have to build something like a predictive modeling, filter them out. But with large language model, it's about the prompt engineering, few short learning, significantly reduce the burden of the machine learning people to work on these very detailed specific models. I do see the large language model have a potential on improving the quality itself, data quality itself.
So I can jump into AJ. I was a baby informatician many years back, and one of the very first projects I was involved in was identification of patients who are high utilizers in a payer system. So I was working for Arizona's largest, one of the largest underwriters for Medicare and Medicaid, and was involved in the integration of the HIE. So it was a really fun experiment to try to track down these high utilizing patients. And these are habitually patients that go from ED department to ED department seeking care or stuff like that. So this one really stood out to me was it was an elderly patient who was going to the ED department almost on a daily basis. And so you can imagine how much cleaning up the data it took just to get to that type of information. But we found out doing some more investigation and sending out an individual to meet this patient is that the reason this individual was seeking care every day is because they could not afford a new air conditioning unit. And out here in Arizona, air conditioning it's needed. No jokes. It's absolutely a must. And so working with the leadership of the underwriter, we wrote a check to fix their air conditioning unit, replace it actually, instead of, paying out quite a bit to support their ED habits. So that's where the intersection of supporting a patient at scale using technology.
I love that example. I was at CareMore, which is a SoCal-based Medicare Advantage plan, and we based on similar insights, we had a whole air conditioner program where we'd get seniors air conditioners in the summertime when they needed it. The one example that comes to mind for me, AJ, based on your question, is the way we designed our EMR at Forward. We built our own EMR. And the way we did it was when we first set out to do it, we had our designers, our product managers, and our software engineers come to the clinic and follow our clinicians and our entire on-site team around for like a period of several weeks. And we wanted them to really deeply understand the workflows in the clinic, the workflows between our in-clinic team and we have a bunch of remote telemedicine providers who do video and chat-based care. The way those teams interact with each other, the way workflows across our entire system, because we wanted our EMR to represent and encapsulate that and be able to capture the structured data as these things are happening in our system. And I think the only way you can really do that, unfortunately, a lot of EMRs are designed really with billing in mind. We just put that entirely to the side and said, we're not billing. It's coming back to my point about incentives. We're not billing at all. Let's literally just build the electronic medical record that will best support our clinicians and help us capture this data in a way that it will be useful for building tools in the future. And that led us to build an EMR that looks totally different than any other EMR that you've ever seen. Most of our physicians get here, and the first week they're like, "Oh my goodness, what is this tool?" And then by like the second week, they literally start saying things like, "Wow, it works the way my brain works." Which you never to hear clinicians say that an EMR works the way my brain works is probably like the highest compliment they can give to an EMR. So we feel like we made really good progress by bringing those teams, the clinical teams and the R&D teams together to build a common understanding of what the EMR should be.
Yeah, I know a lot of folks end up spending a lot of time to sort of build templates and things like that in their EHR because, that's how their brain works, right? They're attempting to sort of recreate the workflow in something which, has virtually no structure to it. And, the way that I think my brain works is like the care plan standard. So the care plan organizes all of the information around a single health concern or health problem. And then it says in one place, what are the information that qualifies and helps us to understand this problem and where it is today? And it links that longitudinally over time, which is obviously critically important for most healthcare problems, which are, tend to be chronic. And it also then asks, what is the goal we're trying to reach here? I have found that, asking patients sort of why they care about things has helped me greatly to contextualize our, the care goal that I have in ways that is meaningful to them. So for example, a number of my patients with uncontrolled diabetes have said, well, I just don't want my feet to hurt. And I'm like, okay, well, let's talk about how there's a linkage between your A1C number that you clearly are not internalizing and your feet. Like your feet have a goal too. And so let's all make a shared goal around our feet not hurting, which would be consistent with my goal of an A1C at a certain level, which would be consistent with a day-to-day blood sugar at a certain level as well. So, I think the machines that have supported us in this space for a long time don't, to Nate's point, think like people think. And we want to think both how the care team thinks, but also how the patient thinks. And that includes, I really appreciate them all addressing those barriers that are keeping us from getting there. Because if you can't afford a medication and you don't call me back to tell me that, you will never take that medication and you will never get better. And I can prescribe it all day long, but it's certainly not going to help you. And frankly, that's a waste of my time as well. So I love sort of Nate's comments about the way that they approach it. And I think hopefully moving forward, we'll start to shift more and more in that direction until everyone feels like their needs are being represented in that record and that everyone is responsible for sharing its management.
I love this encapsulation of so many different barriers and so many different ways that you've sort of tackled them, from building an entirely new EHR from the ground up with a more human-centered design thinking to incorporating data insights and social determinants of health data in order to sort of address high utilizers in the ED. I think it just shows the scope of all these different problems and how it really takes dedicated people with a really important skill set and a desire to make things better to address that, because you need to tailor the solution to each different challenge. So making sure we get to a couple of questions. We have one in the chat from an audience member, specifically to Nate, speaking about the tools that you're building to share sort of automated updates and support clinician workforce in this setting it forward that I think is relatively unique. And have you found the implementation of these tools have led to better outcomes, both for the patients that Forward is seeing, but also for the physicians, compared to a traditional fee-for-service practice environment? Do you have sort of an evaluation of what your, clinical workforce retention looks like?
Yep. Yeah, we try to evaluate all the things that we're launching in our system, and we believe a lot of them are having a positive impact on the health outcomes for our members. I'll give you an example. We launched a hypertension program for members who have elevated blood pressures, and it basically involves they come in, they do a visit with their doctor to understand. We're using any data they've submitted remotely or in clinic to identify the people who should be in this program. We engage them in a visit with their doctor where they understand what hypertension is. We do some education around that. And then we push them via our mobile app. We push them regular educational material, because you can't expect to just talk about this with someone in the clinic and expect them to leave with a perfect understanding of hypertension. You want to continue to deliver educational material to them longitudinally so that they build their understanding of what hypertension is. And then we educate them on interventions that can improve their blood pressure, like diet and exercise and these types of things. And issue them challenges, right? Like we say, okay, you're going to try to get this amount of exercise or do this with your diet. And then we look at what they accomplished over the course of the week. And it's it's almost like a choose your own adventure book where depending on what you accomplished during that week, then we know which challenge to issue you for the subsequent week. And we rolled this out as a randomized trial within our own patient population. And we found that the people who were invited to enroll in the hypertension program reduced its intention to treat analysis, reduced their blood pressure by as much as starting a medication, even though we didn't start any meds on these folks. And if you look at the people who actually did the program, it was an even greater drop in blood pressure. And that's compared to regular forward care, not regular primary care that you could get elsewhere, which I'm biased, obviously, but I tend to think is better than your average primary care. And so those are the types of ways that we know that we're driving outcomes for our members. And for our clinicians, we measure burnout rates in our clinicians. We measure job satisfaction. We measure engagement. And I have never worked anywhere where I've seen scores like this amongst the clinicians, and that shows in our retention of our doctors too, which is that people tend to come here and then tell me that it's basically impossible to imagine going back to practice anywhere else.
Well, fantastic. And so I think we're coming up on time, but I'm want to give everyone sort of a last 30 seconds or so to talk about what are the most salient takeaways they want people to come away from when we think about data quality, workforce retention, and the quality of care delivered. So I'm gonna ask Julia to kick us off here, and then give everyone just a few seconds to give a take home point.
I think I saw some questions too that were sort of like, well, how do we get started on this? And I think the first thing you have to do is really look at your data. And I think for some organizations that may be more challenging than you actually think, just getting that data out. As you look at it, you should say, where are all the patients with X? Why do some of the medications look so weird? Maybe people are able to free text things into the record. As you then analyze that data and look, how clean is it? If we do some metrics that we expect to be better, why are they not better? Then you can start feeding that feedback directly back to your care teams. Both the feedback will help them to act on care gaps that are there, but also to understand, my data is being used for something. I should invest more time into thinking about which pieces of information I'm making sure I record and accurately, because then I'm going to get bad feedback if I put in the wrong input. And creating a team of folks, we've talked at NAC for a while about having a team of care team and clinical champions. Have a handful of folks on the ground who both understand some of this, informatics, data, the EHR system and how it works, and have them talk to their peers. Both their peers will raise issues of concern and potential opportunities for improvement to them, but they can also become sort of the a person who can sit down with someone and say, hey, let me help fix your templates. Did you know that you can turn on the dictation in the EHR? Did you know that there's an app for the EHR? Did you know that you can pull down all the immunizations here? Did you know you can make favorites? So all of those things, even improve the thing that you have today, can make a huge difference in the effectiveness of the team and, frankly, their well-being and their efficiency.
Absolutely. Amal or JQ, do you want to lead us off with any last parting remarks?
You want to go ahead, Amal?
All right, definitely, JQ. So I look at us, and I look at the evolution of informatics, and I look at the evolution of EHRs, and we're still evolving it. And my takeaway message is that exactly what we kind of been as a group been really trying to hammer home is that it's a team effort. It takes not only us as informaticians and clinicians working together, but also it takes an effort from the patient too. So it's the only way to evolve, improve the data quality, and evolve the quality of our EHRs is literally a team effort. And I'm going to pause there and hand the ball to JQ.
Thanks, Amal. To me, I think we all agree the large language model and the new technology, they do show a lot of potential there. And it's aligned the expectation of large language model, new technology should be provide the candidates and the choice and then do the tedious work and then improve efficiency for physician, improve efficiency of the workflow, not trying to replace there. And then the current LM, I think something is happening that like from the general domain LM to medical domain. I assume they will see more LLM-based application in this field to improve the efficiency there.
And then Nate, I'll give you the final words as we wrap up here.
Well, I really appreciated this, and I feel like I really learned a lot from everyone. So thank you all. And I guess my closing thought is, I think with all these tools that are coming, I think there's the potential to reimagine the way we deliver healthcare in a way that we really haven't had the opportunity since like the post-World War II era, when our healthcare system as it exists today was basically formed. And I think if we push for the right tools and we push for the right incentives, the next 15, 20 years could be the most exciting time in healthcare. So excited to see what we can all do together.
All right, well, thank you so much. And I want to thank all of the members of our panel, Nate, Julia, Amal, JQ, for being such a fantastic group. I think we probably could have made this an all-day session and not of things to talk about. And so thank you all for presenting, and thank you in the audience for coming and listening and for asking your questions. So I think this was a really fantastic seminar. I feel like I learned a lot, and I'm even more excited to go out and hopefully make those changes that we see in the world to make things better, sort of bit by bit.